We are back again for another in our series of guest lectures on emerging trends in health informatics. And I've got Reza Barenji here. He's a clinical professor at UCLA, specializing in the application of artificial intelligence in imaging. Reza is a former HINF graduate. He graduated the HINF master's program many years ago.
Yeah, I put it there 2001. So,
and he's worked ever since, and he's back to talk to us. So because we're a bit late, I'm just going to pass it right over to Reza to begin.
Okay, thank you. Can you hear me online? Okay.
Yes.
Okay, good. Hello, everybody. I just go straight. It's good to be back here, especially on a nice sunny day. And I appreciate you guys spend the time coming to the class and stuff, going enjoying the day. We're going to have rain more. So, as Simon said, I graduated in 2001 in master's degree. At the time, master's and graduate studies were not part of the program, like they were by special arrangement. So it was really nice to see now we have established programs and a lot of interest in graduate studies. So my disclosure, I'm not an AI expert. And I don't think the people who are actually writing the programs for me are not AI experts. We're all learning. So it's just at the beginning of a big change. I have some research funds from Lantheus, and Lantheus is one of the companies supporting this AI software that I'm going to present at the end of my presentation. And what I'm presenting here is my own personal opinions, not related to the my employer or other entities I'm affiliated. So let's, I always like to know my audience. I know that the online audience is really hard, but the class here, I know most of you guys are at the beginning of the program, but how many of you have any background in healthcare or similar? Raise hands if you know. How many of you have been to doctor? Okay, good. So yeah, some people, I think all of us at some point, even when we were young, we went to a doctor. So some of my talk is, when we started covering this lecture, my idea was to talk about the imaging standards and an introduction to radiology for you guys, because that was one of the things I thought we have to kind of emphasize more in the program. We're very strong on the HIS part, but not much on the imaging informatics. So I'm going to give you an overview of the imaging department workflow, some imaging standards, PACS systems, then a very short overview of artificial intelligence history and definitions. And then we go right into artificial intelligence or application in imaging, and then follow up with radiomics and that specific program that I'm using for detection of prostate cancer in our patients. So this is a workflow of an imaging department. So I think some of my slides are covered by the Zoom. Let's see if I can minimize this so you can see the whole thing. So I'm sure you guys are familiar with electronic health record, and as you go through your visit with the doctor, the first step is to get registered in the electronic health record. So each person has some identity in that, and then you see your doctor, and if there is a need for imaging, the doctor orders the imaging study. So the next step is that order is being transferred to radiology information system, or RIS. And the scheduling, it can be done by a person, or it can be automatically. So you go on a web page and schedule your study. And the next step is that when you have your appointment, you show up in the clinic, and then you go through the imaging study. It can be a chest X-ray, or CT scan, or some other thing. And the modality is actually the camera or the imaging equipment that the patient goes through to get the imaging done. Once the imaging is done, then we have to send it somewhere to get archived and stored, and that's the PACS system, or picture archiving and communication system, that I'm going to go in more details in my other slides. And then once the images are on the PACS system, then the doctors, the radiologists, or their imaging professionals, they open up the studies, they look at them, they interpret them, and they put a report. And the report goes back to the electronic health record for the referring physician to look at it and see what was the abnormality, or if it's related to the patient's problem. And please stop and ask a question if you have any question, or there are things that you don't understand or not clear. So like many other fields in health information and computer, we have to have some standards. We have to speak the same language when we transfer things back and forth. The same way your cell phone sends some packets of data, we have to have that kind of standards for imaging as well. And many years ago, American College of Radiology with some other entities, they got together and then they had many meetings to discuss these standards, and they came up with DICOM, the Digital Imaging and Communication in Medicine. So this is the international standard for medical images and related information to those images. And it defines the format and the quality of the images to be exchanged. And so there are two major components in DICOM. First is a standard for transfer, sending and receiving images. And as I describe a little bit more later, the quality of images. Once you move from one center to another, you have to get the same quality of image. And that's what the DICOM is designed to do. So this website that, if you guys are interested, is dedicated to DICOM and has many pages of information about DICOM, about the history of DICOM, and then different standards and services for DICOM. So who needs DICOM standards? These are mostly used by, first of all, the physicians to access the images, to review them, and then look at the reports of those imaging studies. Patients, they go through patient interfaces and they can get their own images. Now they're able to see their images and reports as soon as they get reported. Of course, hospitals, clinics, and imaging centers and imaging specialists, they can seamlessly manage, get the images and distribute it. There is a, I don't know if you heard of exchanges, health information exchanges. Those are standardized center, or like you can say they're like data repositories or some interface that as patients move from hospital to another hospital, the old system, or unfortunately current system, is to copy all the images on a disk, and then the patient has to carry it with themselves and take it to the other place. And imagine if somebody has an emergency, there's no time to get those. So that's why the idea of exchanges came, and then the images and also the patient information can be exchanged between hospitals, at least at the local level. And some hospitals, like the one I'm working, the VA hospital, we have a national network. So if the patient moves from one hospital across the country, we can request their data and it gets transferred to us. So that's why having standards for imaging is important. Just like HL7 that we use for our data that's being transferred, DICOM also helps with that. And of course, manufacturers of imaging equipment like CAT scan, MRI, ultrasound, and other, and the software like HIS, recent PACS, and peripheral equipment, they have to standardize their system to comply with DICOM. So they have to have DICOM compliance. But the caveat is, although DICOM is standards, but there are flavors to DICOM. Of course, DICOM had versions, and each manufacturer had a little bit of difference. And I kind of give you a little bit of idea how it is. But for the most part, DICOM is the thing that everybody has to have in order to survive in the industry. And of course, probably not applying to Canada, but in the US, the payers probably save money by having this standardized imaging, and then it facilitates transfer of images and in general saves money. Any questions so far? Now, the key concepts for DICOM, of course, you can get more details on that webpage. So it basically, the concept is the images contain the data related to that image with them. So as the image is being transferred, they don't get lost and mixed up with other things. So information like the patient name, patient ID, institution, the type of imaging, the modality, they're in each individual file. And these files, they have as I mentioned here, have the extension of .dcm. So you get this CAT scan that has thousands of files in it, and each one is individually showing one image at a time, but all of them contain that DICOM header, which I'm going to show in the next slide, that contains details about this study. So when it gets transferred from one place to another, it carries the information with it. And it's very important and very helpful. And the other component that I said is image display. So when you acquire an image and I look at it on my monitor, on my system, and then I give the images to another radiologist, they have to be able to see the same quality of images. And that's very important. And that's an important part of DICOM, that if your display and the imaging system is compliant with DICOM, you see the same level of shades of gray. And the grayscale, it's very important because we do our diagnosis, especially on x-rays and mammogram and everything else, based on what level of difference in contrast we see. So if we're not standardized, then my readings of an image is completely different from another person. So it's very important to have that DICOM compliance. And when you buy an imaging system and the monitors, they are DICOM compliant, and once in a year, we have to do some standardization, and then physicists and other professionals come and check everything to make sure they're still compliant with DICOM. And of course, the services I'm going to show in the next slide. I'm going to go a little bit over the details of it. So this is an example of just part of a DICOM header, and I don't know if you can make out, probably your eyesight is better than mine, but as you see, there's like information about, like on this side, there's a study date, series date, study time, and here we have some institution name and institution address. So each one of these has a tag, so it's a reference number on the file, and then each one is related to a piece of data. But as I said, there are versions of DICOM, and each manufacturer may have a little bit differences. So when we get a new equipment, our PACS people, IT people with the manufacturer representatives, they have to work together to make sure that what is in their tag is compatible with our PACS system. For instance, the physician name may be in a different field. So what they do, they create some sort of interface. The PACS has that ability to move these fields. So when you actually look at the final image, you see the patient name in the right spot. So it's like having two different databases, but not a whole lot of work. So this is an overview of a picture archiving and communication system, or PACS. The PACS system is the heart of an imaging department. It's basically how we do our business in the new department. So old time, there was a whole different story. We had rooms full of films, and we had to run over, give the patient name, and get the actual physical film and run back to our conference and show the images. And guess what? If the previous person forgotten to bring the images, then they're out of luck. So they're still like that. They fell asleep the night before, and the images stayed with them, so there was only one copy. So this is actually a big change for our imaging departments. So, and of course, in the core, the PACS, the picture archiving system is storing data. So that's the major component. But if we just follow the same workflow that I showed, when the patient gets registered in the radiology information system, then a work list, a modality work list is being created. And what is modality work list? When the patient shows up to get his images done, the technologist goes there and check his monitor, and the patient name is, or all the patients that have an imaging study that day, they're all listed there. So instead of typing the name, he just picks the study and he knows what to do after that. So then after he picks that, then the patient goes to the scanner, either like ultrasound or X-ray or some other thing, and they finish the study. Then they transfer that to the PACS system, And the modality basically sends the information there and acknowledges that the study has already completed. And then the radiologist, this is query and retrieve is another part of DICOM. So there are different methods of getting the images. Usually we get a work list of what we need to do, or we just search for all the CAT scans or CT scans that are done or x-rays. And then the radiologist starts reading them and generates reports. And these reports are transferred to archiving with the PACS, and also being transferred to radiology information system, and from them it goes to the electronic health record. So some places the electronic health record and radiology information system, they are one system, and some places they're separate. So, but then the final result is the same. So the doctors log into the electronic health record and they get the reports. So in the process, like the old time, this is not really used that much, but there are film printers, and the DICOM print option allows the users, if they need hard copies of images, like I don't know if you've seen people going for ultrasound when they have a new baby and they get an ultrasound, they want to see the picture of the baby, so they can't really get a tablet. They print it on a little thermal film, so the mom and dad can take it around and show it to everybody. This is our new baby. So that's DICOM print basically that allows that. And more importantly, the media storage, that's the offline, or when the patient wants to move from one place to another, the DICOM media storage allows the copying the files on other type of storage, including DVDs. Any questions so far? Yes.
Good question. So, is there something? Is there any technicality that can whether that is a baby or just intruder?
Say it one more time.
So you're going to take an image for security, right? So if that is just a baby, so you probably don't need to open the camera to waste money on the bill. But if there is someone is not expected, then you probably need to open camera, recording what's happening, even alarming. So is there any technicality that it could just identify itself?
I think this question is about security, is that right?
Yeah.
Security, yes.
Yeah, these are for diagnostic imaging, is that right?
Yes.
Yeah.
So the camera, well, sorry, we use the camera, but this is a imaging equipment that acquires, depends what let's say, if you're doing a CT scan or CAT scan or computerized tomography, it uses X-rays. So the X-ray goes through the patient's body, and I'm going to show some of the images so you get just the images what's inside the patient. Now, technically, you can't see the face of the patient, but that's also changing, and there are AI programs that kind of reproduce the patient's face. So that's the new security threat, that they can reproduce. Yes.
But does the system know what is scan?
What kind of scan?
Yes, does the system recognize that?
Yeah, so each one of these, let's say the equipment acquires certain type of studies. Let's say this is a CAT scan, it just acquires CAT scan, or it's an ultrasound, it's just ultrasound. And that modality basically sends the information to PACS, and one of the items in the DICOM is basically defines what kind of modality that's. So basically, PACS system categorizes it, sends it to the CT scans or ultrasounds or other imaging modality. So that's.
There's some defect on the scan. Does the system know it, recognize it?
So if there is a defect, like if there is a malfunction, is that what you're saying? Yes. So that's a great question. So we have the standards that every morning or beginning of the day, we have to run some tests and calibrate the scanners and do some, they call it quality control. So when the technology starts in the morning, depends on the type of camera, they have to do some standardized imaging. And by law, you have to keep track of that. So every day you have to do this, almost an hour work at the beginning of each shift. And then they have to run this test and make sure the equipment is works as it intended to do. So if there are any malfunctions, then you can't put any patients. And so you have to pass that quality controls. Yes, good questions. So, and there are, I think, different methods. Sometimes you put we call it a phantom. It's just a standardized phantom. You image that, and it has to basically pass that quality control. But that was a very good point. Thank you for asking the question. All right, so I think with that, we're done with the beginning, going over the imaging, and I'm just going to move to our next part of the talk about artificial intelligence. I'm not going to spend too much time on that. It was the term introduced in 1956, so it's been a long time, in a workshop in Dartmouth College. And they defined AI as intelligence demonstrated by machines, in contrast to the natural intelligence displayed by humans and animals. So the first generations of AIs were the expert system. You might have heard of them, like Dr. Watson or some other programs that the IBM brought at some point. They were trying to replace doctors, but they failed. So they're just gonna. Sometimes you can put it in the Google and gives you some diagnosis, but it's not. So after that, then they switched to machine learning or deep learning, and this is also a good article if you have time. It's basically what it says is basically AI for non-AI professionals, and it shows the relationship between different aspects, like different types of AI, the machine language and then neural networks and deep learning and convoluted neural networks. But in a nutshell and very simplified way of describing it, the machine learning, as it says, you have to feed data to it. So it goes through the data. So you need massive amount of data to train an algorithm to be able to recognize and do what is intended to do. And just to give an example, let's say if you want the program to see a brain tumor, you have to first give a lot of images about the brain. So it first learns about the anatomy of the brain, and then it starts recognizing the anatomy of the brain. And then if there is something unusual, then it picks it up. And then in terms of machine learning, some are supervised, means an operator works with the machine and kind of corrects it. And some are unsupervised. So unsupervised one are cheaper to do because you don't have to anybody to sit there, but it takes longer. So, but regardless of that, you need massive amount of data. So that's a big need in the industry right now to get relevant data and use it to train these systems. And we're going to discuss a little bit about the ethics and other issues that comes with that. So, but in general, for the most part, even you talk to the makers of the programs for artificial intelligence in medicine, and they give you this black box definition. So they can't really describe what it does and what it does. So, and then it causes some problem. Most and foremost is exaggerated expectations. You don't know what it can do. So something, oh, it can resolve all problems or something. And the other thing is when you don't know what it is, some people, they're scared of using it because you don't know what it does. Is it really doing what it's supposed to do or not? So these are the important topics for future. And with that, I'm just going to go over some quick overview of if there's no questions so far. Everyone's good? So this is basically similar to what I discussed before on the imaging workflow. So the first phase here, this paper refers to planning, but that's where the patient comes to the department to get the imaging done. So one important thing is, yes, we get requests for patients unless they want to get a chest x-ray, they get a heart scan or something, but is this scan really needed for this patient? So right now we're doing it manually. So like either the radiologist or the technologist or the clerk, they have to go check and see if this patient really has heart disease they ordered. So that's very time consuming. But And I want to emphasize this part that I'm talking, it might be the probably most important part that you guys as the health information experts can help. And it's pretty much untapped. The other parts, the scanning, reading, and reporting deals with image analysis, and that's almost 70–80% of programs are designed to do that, because when you say imaging, everyone wants to work with the images, but they basically forget that business part. And I'm going to discuss more, because that is where in the future, I guess near future, you guys can help. And you can basically, with your knowledge of health information, you can use the programs to alleviate some of this problem. So scheduling of a patient is important. Right now, it's just human factor. We go and find the empty spots and put the patient there, but AI can optimize based on the time of the day, based on the number of staff that you have. It can kind of make tailor your schedule. And I'm going to discuss more about no-show, because we schedule patients and sometimes they don't show. It has multiple problems. One of these is lost time, and the patient has to come back another time. And we don't have a way right now to kind of predict which patient may not show. And there are ways to do it. Like some patients, they're too sick even to get to the hospital. So we can't really go and review everything and see, oh, this patient have end-stage disease or something, or needs transportation, or some many factors influence their ability to show up. And it's of course lost money for that clinic or hospital if they schedule a patient and doesn't show up. And in the fields that I'm working, we're using material that expires. We're using radiation, and then they have short half-life. After a few hours, they're not useful anymore. So if we schedule the patient to come in and they don't show up, then all that material is lost. And some of them are thousands of dollars. They're very expensive. And sometimes we have shortage, so we have to make sure the patient comes. And then the other aspect that we are pretty behind and can do it is getting some information about the patient's disease. Right now, we get, like, if we're lucky, we get one line from the referring doctor because they're busy. They just say, patient with chest pain, and they send it, but they don't give us any details about. And then sometimes we have to go back and spend hours and to find out what kind of chest pain the patient has. Is it related to a cold, or is it related to heart disease? Does it really need to get a heart scan, or need just a chest X-ray or chest CT? So that's another part that the AI can gather relevant information and present it to the physician or a person who's scheduling. Protocoling, so the protocol is when the patient comes, like we have maybe 100 types of CT scans. We have to know what area of the body you want to cover. If this is a smaller patient, if it's a baby, we have to use lower radiation. If it's a bigger person, we have to use a higher amount of radiation. And we have different type of CT scanner. One is designed to get fast. One is designed for better resolution. So, and it takes time for the person scheduling to put them in the right spot. But the AI can be helpful to minimize the basically work of the clerk or person there. So the other thing is, what are the preparation for this study? Some studies, the patient has to come without eating anything, they have to fast. Some of the studies, they have to eat a little bit of food because you're trying to see the stomach or something. So, and those are the things we have pre-printed instruction, and when the study request comes, we send it to the patient. And of course, sometimes the clerk is busy and they send the wrong instruction. So a patient comes to a study and they were not supposed to eat anymore. So I didn't receive it, or they send me the wrong instruction. So that causes delay in imaging. So the AI can be helpful in that too. And of course, if they have allergies, we use iodinated contrast, and some people are allergic to it or some other material. So that's also important to know ahead of time and prepare for it, or delay the imaging study. And of course, it's important, once the scan is done, once the study is done, it goes into the queue and the radiologist reads them as they come. but there are patients that are in the emergency room and they need this study to be seen right away. So the AI can go through the study, either pick the right patients that are in the emergency room and need the study right away, or even go through the findings. And if they have some significant abnormal finding, let's put them higher in the queue. So these are things that I think more of the business of imaging versus the actual images. And that's what you guys are coming into, basically using your knowledge to help out. And of course, the rest of it, scanning, reading, and reporting, these are mainly related to the quality of images. We can use AI to use less radiation. We can make the image quality better and faster images. And of course, in the reading, that I'm going to go into detail in the software we're using, the AI can pick the abnormal area. And of course, another radiologist have to double check and make sure that those are the correct diagnosis. And then it can generate a structured report and the doctor can approve it. So those are mostly the imaging business of AI. And this website, AI Central, is the American College of Radiology dedicated website for mostly the imaging AI applications that are approved. And if you have time to check it out, it divides it based on different modalities like CAT scan, MRI, and other, and different body parts. So it shows, and it is pretty small, but I encourage you to go back and check it. It's interesting to see what body parts and more AI software dedicated to them. And I think every few days, if you check, there might be more applications coming out and get FDA clearance to be used. So again, to emphasize your part in this, this is basically another good paper that talks about the business of imaging. And as I mentioned, the scheduling, the appropriateness of the study, optimizing the protocol for the patient, and then adjusting the workflows. If one technology is doing too many works and the other too many studies and the other one is not, then it can adjust the workflow, so send some of the patients to the other technologies. And of course, in reporting and communication, and not much for Canada, but in the US, the billing part is also important. So these are the areas that you can read more about it, and in the future, you can probably participate in projects as the health information expert to provide your insight. Because yes, the mathematician and computer programmers, they know a little bit, but I guess you guys can give input because you're familiar with the data flow, and that's very important. And with that, there is another type of AI system that are gaining attention, and that's consumer-based AI systems. With patient interfaces, the patients can go to their charts and look at all these jargons that we as doctors putting there, and even one subspecialty to the other one, we don't understand our own language. So imagine now patients that have a hard time. So this one particular paper looked at acceptance of artificial intelligence by patients. So when they open their radiology report, it basically reviews it and it highlights the area of abnormality. So it is one step forward to just make it more understandable for the patient, because and I get phone calls, they have their reports and everything is normal, but then the way we wrote it, they're all scared. So they call and say, what is wrong with me? And I say, no, there's nothing wrong. But that kind of takes that stress out of their day-to-day life. And in some cases, they have serious abnormality that they need to know about. So some of the challenges of AI, data governance, the robustness of algorithms, and creating consensus for stakeholders, and legal liability. And this image that was from this nice article kind of describes it. So data governance, as I said, for these for the software, to get trained, you need massive amount of data. So one way is to get prospective data. So each patient comes, you give them a consent form, they sign a consent and say, okay, I agree to use my data, but that's kind of for the future. But if we need the data from the back, that's retrospective data. Who owns that data? And if it's ethically correct to use them, and I guess some health systems, they use the data and the consumers were not happy about it because they gave the data to private entities. So these are concerns and that everybody has to keep in mind. Who manages that data, and then is this data good quality data or not? So these are things, because we think, yes, this is artificial intelligence, it can do everything, but it's not true. If you train them with the wrong data, and then that's another one. If the data is biased, and we have a lot of biases in medicine, if you train them with wrong data, they're just going to give you the wrong diagnosis or detection of things. And that's also goes into the algorithm robustness, and adversarial attack is a term that is used when you give wrong, noise and other wrong information, then the application actually gives you the wrong result. And an example of it that this paper mentioned was, at some point, I guess, Microsoft released some in the Twitter a program that was responding to you, and people overwhelmed it with bad language, and it started replying with bad language. So it was not the intentions, right? So they stopped it, I guess, even after a few hours. So it's the same. If your AI program is being trained by wrong data, or if your image qualities, as the other gentleman asked, if your scanners are broken and you give them wrong information, then every normal person may get a diagnosis of cancer, and that's disaster. So they have to. So these are all other things. And one important thing is, when you talk to the manufacturer of this program, I think that this paper said about 60 to 70% of them, they can't even describe how their algorithm work. So they don't know how it works, basically. So and then they can't give you a percentage of correctness of this algorithm. So these are all things that needs to be defined, because we're dealing with patient's life, and that takes it to I jump to the legal liability. Who's liable when you're using this program? Is this the doctor is using it, or the program? So these are things that needs to be clarified before we get. And of course, putting the stakeholders together, the consensus. This includes the consumers, of course, government agencies, the private companies, and other entities to get together and find out how they can really address the issues that are related to use of artificial intelligence in imaging. What are we doing with time?
We're okay, we've got half an hour.
Okay. All right, so with that, I'm gonna move to radiomics. That's the part that I've been using and working in the past few years. And this is the part of AI that uses images to extract information and data, and basically it aims to extract quantitative and ideally reproducible information from diagnostic images that includes the complex patterns that are difficult to recognize by our eyes. So the image, when we look at it with our eyes, we have limitation of seeing all those details. There are many different aspects to an image, and I show you an example. This is a chest CT. So this is this is the lung, and that's part of the heart, and that's the chest wall. So this patient, as you may see here, there is some area, an unusual, that is different from what is around it, and we call it as a lung lesion. And then this was a region of interest was drawn. Either it can be done automatically, or a user draw this, say, oh, I think there's something abnormal there. So the program extracts the information. It's the shape of it, how much intensity is, and that's what the grayscale comes into account. There are shades of gray to this, and as you see, in our eyes, probably I say, okay, this is probably similar to area next to it, but as you see, there is a spectrum of grayscale there that we may not be able to see it clearly. So, and then there is a different texture to it. So the AI system extracts all that information, and based on how it was trained, it can, like in this chart, it shows, yes, if this is a cancer that looks like this, the blue line are the patients who are, responding better to this therapy, and these are the red line are the ones that are not responding based on the text, the pattern and shape of this disease, and then it categorizes this patient. So, okay, based on the information we have, this patient falls into that blue or red category. Or in the bottom here, I don't know if you can read it, it's basically if the red dots are the benign lesions, and then the blue dots are the malignant lesions. So based on the shape and texture and pattern of that lesion, if this falls into a benign lesion versus a malignant lesion. So these are the things the radiomics try to address, getting more data out of these images beyond what our eyes can see. So now I'm gonna focus on the projects we are doing at UCLA. And so basically we're working on prostate cancer, and just a quick overview. Prostate gland is, it's of course in men only, and it's right below the bladder. This is a histological cut of the prostate gland. Like other organs, it can get cancer, and it's unfortunately very common. About 190,000 men diagnosed with prostate cancer in 2020 just in the US. And unfortunately, 33,000 men died of prostate cancer in 2020. So it can be a lethal disease. And it's very important to know if the prostate cancer is localized in the prostate gland or is metastasized. And that makes a huge difference for the patient. And then the treatment options are different. Even if the disease is outside of the prostate, is it one area affected or many areas are affected? So these are the things that we try to address. And for that reason, of course, clinical exam helps a little bit, but you cannot see inside of the body by just looking out. So we have to use imaging for that. And there are different imaging modalities, like bone scan looks at the bones. Positron emission tomography, or PET scan, is the one that actually I'm using for this program, and we're going to talk about it. Ultrasound, MRI, and computed tomography, they're all modalities that gives us some information, but today I'm going to focus on the positron emission tomography. Now, to know a little bit about positron emission tomography, basically, in a nutshell, we inject the patient with some material that is connects to a biomarker of something that we're looking at. Let's say we're looking for prostate cancer. We have to have some material or a molecule that goes and attaches to those cancer cells. And in order to see them in the body, we tag those biomarker or the material with radioactive material that emits radioactivity. And the PET scanner, as you see, is a ring of detectors that detects the radiation that comes from the patient. So we basically inject the patient, or in some cases, the patient can swallow it. It goes through their body, it gets absorbed. So we have to wait a certain amount of time for this material to circulate in the body and gets absorbed. In our case, it has to go to the prostate gland. And sometimes we have to wait for the additional material to come out of the patient's body. It either comes through the urine or through the liver. But after a certain time, then we put the patient on this huge scanner with all the detectors around them, and it starts reading the radiation coming from their body. And the areas that have extra radiation, it creates an image of that area. So for prostate cancer, of course, there are several biomarkers. What we are currently in this project using is called the prostate-specific membrane antigen. This particular glycoprotein surface enzyme is on the surface of the cell, but it also has a an area that goes inside and is by a factor of 100 or 1,000 folds more on the prostate cancer cell. So there are other normal body parts that have that, but the prostate cancer cell produce 100 or 1,000 times more than other places. And then, of course, prostate-specific membrane is a misnomer. It's both, you can find it both in male and female, but it was, called PSMA or prostate-specific membrane antigen. But there are other cancers in male and female that can show this kind of glycoprotein inside. So then, after recognizing this, we have to tag it with some radioactive material. And then for our research, we use a fluorinated compound. That's the F18F is. So the whole idea of radioisotopes or radiotracer is we have a radioactive material that disintegrates over time and releases radiation that are detectable by our cameras, either PET scanner or CT scanner. And then for this purpose, we're using this compound that's called 18F DCF-PyL. And that's an example of a scan we did. So this patient had an MRI scan of the prostate gland, which didn't show. This is some of our data that hasn't been published. But on the other side, this bright area is the radiation that was absorbed into that cancer cells with the PSMA. So basically, it lights up in a kind of simple language. It lights up and we can see it. And these are additional images. So, and it can be just uptake in the prostate gland. This is the bladder and the prostate. Of course, other places like the salivary glands, liver, and kidneys also show activity, but these are normal. And then as you see, these are different patients. So the number of areas, you see all these black dots around, and unfortunately, this patient has disseminated disease. So this is important to know that the type of therapy we do for this patient is different from this patient. And then the prognosis for this patient is different from this one. So we tell the patient, oh, you have to get this kind of therapy versus the other one. Some may just get a surgery, some may get radiation therapy, some may get chemotherapy, but it's also important, always important to recognize that. So these are the ones, the areas that we need to answer. We have to assess progression of the disease over multiple scans. So the patient comes, they're newly diagnosed, and every 6 months or a year, depends on the disease, they come back for a follow-up scan. So we have to get that information and accredit. We have to, sometimes we give patients some therapies and we want to see how they respond to the therapy. If they responded properly, we continue them. If they don't respond, then we have to change and use a different method for the treatment. And then we have to see how much of that PSMA is basically there. Avidity means how well they take it, they pick up. But then there are barriers. It's time consuming to go through all this little by little and get, how much uptake is there and give it a number. And it's manual work. It's sometimes not reproducible. So if I do it versus someone else, we may get different results. And that's one of the factors that may affect the patient care. And it is not standardized. So with that idea in mind, we work with the company to create a program that can kind of facilitate these needs. So if you pay attention here, we have the PET and the CT. This is called a hybrid imaging. Hybrid imaging means we combine two of these imaging modalities together. And the reason we're doing this, because some of them show anatomy better and some show the function better. So the positron emission tomography shows the function or uptake of those PSMA. But CAT scan shows an excellent details of anatomy of the body. So when you combine two, you put them together, then you see the activity and you can pinpoint in which part of the body it is located. So this is just a So the patient gets a CAT scan with the PET scan, so they're together. And then we run this through the AI system. And the AI program does a segmentation. And what segmentation means, the program tries to recognize different body parts. And as you see, it gives it different colors, like right and left lungs, there are different colors, liver. So it basically creates this standardized segmentation that it recognizes these are different body parts. And then the next step is it looks at the PET scan, and that's the PET scan of the patient with all those black dots that are shown in the other images. And those are the areas that unfortunately the prostate cancer have got, kind of metastasized, and it tags them. So it gives it a specific color. And then it has to find some normal areas, like, you know, for this instance, it uses liver and activity in the blood as a standardized amount. And then it calculates a factor and then gives a number to each lesion. But the important part is a physician has to review this and validate it, because it cannot be used independently. And of course, it gives you a quantitative output with a report. So that's basically showing the same thing. So it picks all these lesions and then color coded, and each one has different amount of activity. So it lights up more or less. And then based on the relative uptake to the liver or blood pool, it gives it a number. And this is also another depiction. So as you see, each vertebrae has a different color. The ribs are different, have different color, lungs, liver, each body part has its own, basically the machine sees it differently. And then it overlaps the PET and picks up all these little areas that are involved with prostate cancer. And basically at the end, it gives us a report. So we can use this to send it to a physician, or use it to basically evaluate the patient, and we can do this over time with different treatments. So this is what we were doing in the past few years. We've published a few papers, but still there's a lot of more work to do. So we don't think it's going to replace our jobs for now. So we're safe. All right. In summary, I think the artificial intelligence application is rapidly expanding in imaging. But majority of these applications are focused mostly on image acquisition and processing. So it may be the time for health information professionals to use their expertise to expand AI application in business aspect of medical imaging. And with that, I hope that you guys start looking into this, and maybe you're maybe not the first co-op work, but then maybe the second or third, you find some interesting areas that you can kind of contribute to this. And with that, I guess I'll end my talk. Thank you for listening.
Thank you very much.
Sure.
Appreciate that. So from the audience, you mentioned that magic word co-op.